Very nice to see you all. I'm Philip Bloom. I work at the Western Eye Hospital in London. I'm a glaucoma and cataract surgeon. And not all glaucoma surgeons consider themselves cataract surgeons as well, but I do. I have had leadership positions in both fields in the past. These are my financial conflicts and potential conflicts of interest. Most glaucoma treatments are, of course, outflow procedures, trabeculectomy, PreserFlow, tube surgery, or hybrid devices. And very few surgical treatments target inflow. So endoscopic cyclophotocoagulation is unique in that regard. I'm going to talk a little bit about balance between inflow and outflow and how that affects my thinking about when to do this procedure. Some indications. I'll discuss some of the quite large body of evidence supporting this treatment and tell you where I use ECP in the treatment paradigm. We know that the aqueous is produced by the ciliary body and drains via a variety of mechanisms. And in the past, inflow has been targeted, but by some very blunt tools: cryotherapy, YAG laser, thermal diode laser, applied externally through the tissues of the wall of the eye. The introduction of endoscopic cyclophotocoagulation was a real advance in this field, because it allowed the target tissue to be viewed directly and the endpoint for treatment to be finely judged. Personally, I use ECP in a variety of situations. I regard it as the original MIGS because it is conjunctival friendly, minimally invasive, done with cataract surgery. But I also use it later on in the treatment paradigm after a suboptimal result from traditional surgery. So it's actually of use throughout the treatment paradigm, not just at one point. This is just a very busy slide talking about how aqueous is produced. This is, again, a little bit of the history of glaucoma surgery. There have been some surgical inflow procedures, a cyclectomy, but they were devastatingly complicated, high risk of phthisis. And of course, it is true that still other forms, the more modern forms of cyclophotocoagulation are still tainted by the association with these very inflammatory historical procedures. And so there are people of my vintage still who remember cyclocryotherapy, YAG laser treatment, and know quite how inflammatory that is. These are now, of course, outdated techniques, and we don't use them anymore. This is, again, the spectre of phthisis and sympathetic with these treatments is, and I won't dwell on this because this is not ECP, this is the transscleral, but that sort of horrible inflammatory reaction, if you compare that, the beautiful, controlled, gentle effect that we get with ECP, you understand why it has such a favorable safety profile. So when I started, diagnosis was easy. We only talked about pressure, and then this was the place of cyclo-destruction, as it was called then. Now, we're much more nuanced. This is just saying that it's never made a lot of sense to reserve cyclo-destruction for the end of the treatment paradigm, because at that stage, although the pressure's raised, the outflow can be almost zero. And, you know, the outflow mechanisms can be completely shot, and therefore the inflow is vastly reduced as well. It's still there, but the balance between inflow means that the pressure's too high. If you try and treat an eye like that with cyclophotocoagulation, you're on a knife edge, and that explains why some of these patients went soft and why some of the results are were poor in the past. So I think it doesn't make a lot of sense to reserve cyclodestruction to the end. It makes much more sense to have it earlier in the treatment paradigm, where reduction in the inflow has a better chance of affecting the balance between inflow and outflow. And that's really very analogous, using it early in the treatment paradigm to other forms of treatment. For example, SLT is now taking the place of drops, and MIGS are, and I would class ECP as a MIGS procedure. MIGS are often supplanting the use of more invasive drainage surgery procedures. So the endpoint is shrinkage and whitening of the ciliary processes under direct vision. And in a primary eye, a phaco ECP eye, I will do 360-degree treatments without any concern. In an eye that has more advanced glaucoma, if it's had previous surgery, then you might want to be a little bit more cautious and either treat 270 or even 180 and be prepared to repeat the therapy so that you are take a slightly more cautious approach. This is the beautiful 19-gauge 3-in-1 endoscope combining imaging, light and laser with an aiming beam. We were fortunate enough to run one of the wet labs at the MIGS masterclass, and we got some extremely positive feedback from all of our students, as we do with everyone who uses therapy. It's an incredibly attractive and neat solution to the problem, and a unique one. So this just shows the evolution of the imaging through the years. This now is the beautiful view you get through the 19-gauge endoscope, 17,000 pixels, and is perfectly placed for this treatment, but also it's really useful for other forms of complex surgery. I use the endoscope to resite glaucoma drainage tubes into the ciliary sulcus. In trauma, it's very useful. So the camera of the endoscope itself has lots of other uses as well. So this shows viscodilatation of the ciliary sulcus, and the endpoint for treatment is the whitening and shortening. And it can be done in pseudophakic eyes through the limbus. It can also be done through the pars plana. It can technically be done in phakic eyes, but it's not my practice to do that very often. If you do it in a phakic eye, you can only do so through the limbus, because if you went through the pars plana, you'd hit the back of the lens. The only caveat I'd have about doing it through the limbus is that if there are extensive posterior synechia in someone who's had previous surgery, then that can cause a problem. So this is the view. You do it through a normal phaco wound. Very important not to try to make the wound too tight, because then the cornea will twist and torque. And the idea is that this laser is able to be turned within the wound without overly stressing the cornea. That's not a problem with the main wound, which is usually your phaco wound. But when you make other incisions, some people enlarge their sideboard, others choose to make a separate new incision. When you do that, I would urge you to make it at least 1.5 millimeters, if not 2, so that you can access all of the ciliary body by twisting the probe without any concerns about corneal torque. So most of my approaches are done via the front, via the limbus. Occasionally I'll do it through the posterior segment, via the pars plana. In my practice, I do that in combination with a retinal surgeon, but any anterior segment surgeon who's comfortable with vitrectomy can do that themselves as well. And it's very easy to do in the presence of a posterior chamber intraocular lens. It's possible to do it with an anterior chamber intraocular lens. It's a little bit more complex. And in an aphakic eye, I would urge you to use an anterior chamber maintainer and slightly adapt the technique, because in that situation, you're not able to use OVD or viscoelastic to open up the ciliary sulcus. There are two probe designs, straight and curved, both of which are 19 gauge. So it's a tissue-sparing treatment that's applied under direct vision, very different from any of the forms of transscleral, in which case the laser has to pass through a tissue with the possibility for absorption within that tissue. And it is titratable. If you have concerns about the possibility of it being too effective, you can titrate the treatment deliberately into 2 or even more. It's important to treat prophylactically against the possibility of a pressure spike and inflammation. So this is just a schema for how we do it, and this is the end point of treatment. This is the red of the aiming beam of the laser, and as the foot pedal is applied, the ciliary processes shrink and whiten, and that's the end point of treatment. It's incredibly satisfying, incredibly effective, and incredibly safe as well. So this is the view you get. The technique can either be to paint individual processes or to do a painting. It doesn't really matter, whatever works in your hands. Generally with phaco ECP, I'll do a 360 degree, but if you're cautious, or if it's an eye that's sick for any other reason or has had previous surgery, you may choose to do a fractionated treatment, 180, 270. Just to go back, there is also the possibility to do ECP plus, where you indent and treat second rows of ciliary processes or secretory epithelium from the pars plana. That's not often done, and if you do it, be cautious, because it is a very powerful procedure, and in that situation, if you treat too much, there is a risk that the eye, there may be hypotony for a while. So I tend to do it almost with phaco ECP, almost exclusively after the posterior chamber intraocular lens has been inserted. Some people choose to do it after phaco, before the IOL is inserted. That's not my practice. I think you risk damaging the capsular bag. The argument could be you may get a slightly better view of the process and of the pars plana, but that's not my experience. Post-op care, assiduous removal of the viscoelastic, prophylactic treatment against inflammation with intensive topical steroids and non-steroidals, which have the added benefit of reducing the risk of cystoid macular edema, preventing a pressure spike both by removing the OVD but also with oral acetazolamide. And initially, you can reduce one or so of the medications and then sequentially remove them. If it's a very early case and it's someone who's only on one or two medications, you can remove them all and then, if necessary, reintroduce them. But I tend to do it the other way around. Complications, well, people who are disappointed by the treatment probably haven't treated enough, and that does happen early on in your treatment experience because you don't trust the treatment, but trust me, you can. So I tend to do 360. If hypotony occurs, I think it happens because it was a poor case selection or you did too much treatment in an eye that's already sick. Hypotony in phaco ECP is, in my hands, unheard of. Pressure spike, of course, but by prophylactically treating against that, there can be, you don't often see that. So let's talk briefly about the evidence. I don't want to make this a didactic talk, but it is often said that all forms of cyclophotocoagulation are not evidence-based. In my opinion, that is incorrect. There's a huge body of evidence supporting this therapy. It is true that RCTs have been historically slightly lacking, but I think that will be about to change soon. So there's huge bodies of level 2 and level 3 evidence and emerging evidence at level 1. So these are just some of the publications that I've been involved in. And I would urge you, in advance of the level 1 evidence, just the fact there isn't evidence of efficacy doesn't mean that there's evidence of lack of efficacy. And I believe that the level 1 evidence will come in a short period of time. Yeah. So, just a list. Please don't read this. This is just showing that over the last few years there are many studies, and these are all available from BVI if you want afterwards. In supporting use of phaco ECP, and there are actually also 2 Cochrane reviews of ECP, all of which support the therapy. These are the 2 of them, and this is the conclusion from one of them. Given the obvious efficacy of the procedure, there's a place for ECP, etc. So, evidence does exist. And again, these are just some of the other studies in favour of phaco ECP. So I'm just going to briefly run through the evidence for different indications for the use of ECP. This is phaco ECP and the efficacy and the medication reduction. Phaco ECP versus phaco alone. The famous Stanberg paper, which is not in the peer review literature, but which shows what other studies have shown as well. This shows the decrease in medication use. This is a UK paper showing the efficacy and the longevity of the procedure in the British Medical Journal. Obviously, with any surgical treatment, there can be complications. The complications of this treatment are no greater than other forms of MIGS, in my opinion, especially if they're handled well. So, phaco ECP versus phaco alone, well, there does appear to be an added benefit of the ECP over the phaco alone. And again, that's often mentioned as an argument that, phaco surgery always lowers the pressure, so phaco ECP is bound to. Yes, it does, but there is an added benefit of adding ECP over and above the phaco alone. I'm a fan of combining inflow and outflow, and so there is a place for ECP in combination with other MIGS devices. For example, the iStent. This is the so-called ICE procedure. That's the iStent, cataract, and ECP, ICE, showing an added benefit here versus iStent alone. And here ICE2 with the iStent W with 2 iStent devices, This was by my ex-fellow Gok Ratnarajan, who again has showed a benefit of the ECP over and above the stent part of the procedure. And again, this is just further evidence. Again, please don't read it, just know that the evidence exists. Again, more ICE2 evidence. And I've talked about using ECP with iStent, but ECP can be used with other devices. So these are a list of papers combining ECP as an inflow procedure with other outflow procedures. And you can see that additive, it's obvious that if you apply different treatments to the eye that have a different efficacy, you may get an added benefit. And these papers support the efficacy of that strategy. What about advanced glaucoma? I talked about that initially. It does sometimes feel like we're damned if we do and we're damned if we don't. But there's a very, I think, persuasive evidence base in favor of ECP in these refractory cases. Again, lots of papers. And if you compare it with other treatments traditionally done in that sort of scenario, for example, a tube, ECP does stack up very well against them. Here are some studies showing of a relatively high level evidence of the benefit of ECP in refractory glaucoma. And these are just a summary of some of those results. This is one of the ones that is often quoted, where the ECP was head-to-head in really difficult glaucoma eyes against RMED tube implantation. And actually, ECP did easily as well as, if not better than, with fewer complications than the RMED valve, fewer sight-threatening complications, I should say. So in my practice, it has a place in advanced glaucoma. It also can be used in the presence of plateau iris, in the same way that we use atropine or sometimes transcleral to rotate the ciliary processes, for example, in aqueous misdirection. With plateau iris, in addition to cataract surgery, endocyclic photocoagulation will slightly rotate the ciliary body and may make the plateau iris much more favorable in terms of the pressure. The other thing is that because there's no cost per, or very little cost per case, there's the cost of the probe, but it's vastly less than the cost of a MIGS device. Once you've set up your original machine, if the volume is driven, then it can be a very cost-effective procedure. This study from the Medicare database showed that actually it is as effective or cheaper than using drugs, for example. So the indications: primary treatment, it's my phaco plus treatment of choice. It is the original MIGS. Cycloplasty, I think it's a benefit in post-keratoplasty eyes because it's minimally invasive and doesn't cause the inflammation that can sometimes drive corneal graft failure. I think it's ideal in the presence of cicatricial conjunctival disease because you don't have to touch the conjunctiva. And I will always do this if a tube or a trab fails before attempting a repeat invasive outflow procedure. So think about the direct visualization, the benefit of seeing the tritratable endpoint. Transcleral cyclophotocoagulation, in contrast, you're never really sure where it is, even with transillumination, and the levels of energy you apply are orders of magnitude greater, and therefore, not surprisingly, the complications are greater. This is just a slide. You can see with the use of ECP in neovascular glaucoma, fewer papers supporting it. It's not my practice to do that. We know that neovascular eyes do badly whichever treatment you do. Increasingly, we're doing Avastin tubes. So just to point out that some people are getting moderately good results with ECP in the presence of neovascular glaucoma. I do that with some caution, I have to say. Risks and benefits, well, it's an intraocular procedure. By the time of phacoemulsification, it of course does not add any risks over and above those of the surgery itself. And because you're minimally disrupting the tissues, there's no risk of marked inflammation for that reason. And you cannot overstate the benefit of directly visualizing the tissue, knowing the endpoint of treatment, and not risking the collateral damage that is inevitable if the laser has to pass through the wall of the eye and then get absorbed potentially by collateral tissues. This is just showing that it's been well proven that there's a histological benefit of ECP over transcleral, much less inflammatory, much less invasive. When not to do ECP, again, I would be cautious in a phakic or a neovascular eye, or if there are extensive posterior synechiae behind the iris, a little bit cautious. Many more contraindications to transsclera, and in all of these situations, ECP is a good option. So the balance, some people say, why not just do transscleral? This is the answer to that question. So just my philosophy for ECP summed up in one slide. Think about outflow and inflow. And if you can combine the two intelligently, strategically, that will be to the benefit of your patient. The concern about cyclophotocoagulation has always been about its safety. That should no longer be the case. ECP is a safe treatment, as any other surgical procedure. Of course there are risks. The risks are small. So it behoves us to apply the treatment in a way that maximizes the efficacy. And I think if you consider the safety and efficacy, again, it's a very positive balance now. And finally, the ability to see, directly treat, and get the endpoint of treatment with a beautifully designed endoscope on a fabulous screen cannot be overestimated. I'd like to thank all my fabulous colleagues at Imperial, the Western Eye Hospital where I work. And I think we're on time for the presentation, and we can probably take some questions here before we finish, and then we could always move sideways if needs be. Thank you for your attention.